Let's talk about selecting an appropriate ADHD therapy. It's a challenge we all face in our clinical practices every day. We want to have the best possible outcome for our patients, and often it's with the limited information we have in a clinical interview, one clinical interview. So how do you choose? How do you choose the right therapy for your patient? Dr. Cohen, new patient comes into your office. Diagnosis of ADHD is clear. What do you do? What's the next step?
It's a very interesting question because so many more individuals are now being diagnosed with ADHD, whether it be children, adolescents, or adults. So if it's a standalone ADHD case, I'm going to tend to move first to a stimulant compound. So I'm either going to choose an amphetamine-based compound or a methylphenidate-based compound. Stimulants will be the first-line choice.
Now, what's the basis for making that decision? Because it seems fairly self-evident, but is there anything that we can point to in regards to specific guidelines recommended by associations?
There are several guidelines that will point to stimulants as the first-line compounds. The American Academy of Child Psychiatry, the American Academy of Pediatrics all point to the use of stimulants as a first-line compound for individually diagnosed ADHD patients, whether they be children or adults. What we have now is we have a wide variety of compounds even within those two classes of medications to choose from, and they vary in terms of time course and how long they last. Years ago, we would use compounds that only lasted a few hours, which required children or adolescents to take medication through the day. Now we have medications that allow once-a-day dosing that alleviate the need for the multiple doses.
So if I hear you correctly, duration of action is important.
Critical. We're going to choose compounds with a longer half-life or a delivery system that allows utilization of the medication throughout the entire day with an AM dose only.
Dr. Manis, you looked like you had something to say there.
You're going to forgive me because it's something that the medical profession often leaves out in treating ADHD or many psychiatric disorders. It's that the patient needs to be enrolled in the need for medicine. That is, many patients, there's a lot of disinformation out there, and many patients have it. And they often are reluctant to take medicine. And if treatment adherence is to be assumed, we're making a mistake. You actually need to enroll the patient right from the beginning about the use of the stimulant.
So if I'm hearing you correctly, step one for you is the connection with the patient so that they'll even take the medication before you can talk about duration of action.
Exactly right. Letting them know how it works, why it works, and making sure that they have what some people call a buy-in.
The science behind what we do with the medications,
yes,
why
absolutely.
we do what we do.
I agree with you because it really is critical that we manage the expectation of the patient. We know that the patient has ADHD and we know what we believe is the right choice of treatment, but that doesn't mean the patient's going to accept that. I think the first step of treatment is education. What is this disorder? What's the background? What are the genetics? How does it impair your course of life? And then from there, and I thought, Mike, you were going to mention as a psychologist the behavioral treatments. I think that we spend a lot of time talking about medication and less time talking about the psychotherapies involved with the patients. And that gives them a sense of control. That is something they can exercise themselves. The medication is simply taking a pill and hopefully it'll work. But I think a combination of education, behavioral therapies, and medication really is the comprehensive approach.
Well, now, I got to say this too, because you're absolutely right. Behavioral intervention, if you don't mention it, guess what happens? People just use medicine. They don't consider that they can also build skills or get psychotherapy, especially if there's comorbid disorders. And so you're absolutely right. Thank you for bringing that up.
But what? I'm now play advocate, devil's advocate, and that is, what is the impact of behavioral therapy in the absence of medication, and is the presence of medication useful in complementing the behavioral therapies?
That's a rhetorical question, David.
I'd like to put that on hold and stick with the original. So what are we doing? The original question. So what are we doing for the patients in that visit? Where are we beginning? So we're talking about behavioral therapy. We're talking about medication interventions, and we're talking about educating the patients. What is the science behind what we do? What is the neurobiology of ADHD? Where is ADHD happening in the brain, and where are the medications having the impact?
Well, I think the answer to that is we don't really know. We can point to genetic research that shows it's highly genetic. 75% of the cause is genetic. We know that it runs in families as a result, so we look for multiple family members. We have neuroimaging results that show both density, receptor density changes, as well as morphologic changes in the brain. None of that, though, gives you a specific causal relationship of the disease entity to a specific neurobiologic entity.
I think
Dr. Manos, where in the brain are the medications having their greatest impact? And since Dr. Cohen led with the stimulant medications, I'll say the stimulant medications in particular.
The stimulant medications work effectively in the catecholaminergic system. So let's take a look at what ADHD actually is. ADHD is a dysfunction of what some people call executive functions, but let's simplify it even further. You have two kinds of attention. One kind of attention might be called what's interesting and fascinating. Another kind of attention is what neuropsychologists call effortful attention or directed attention. See, the ADHD brain, in a very interesting paper by Castellanos in the last several months, identified or named a default mode network. The ADHD brain always goes to what's stimulating in the environment. But you see, we have to tear ourselves away from that to do most of the work that we have in life. That's effortful attention. It's the network of effortful attention distinguished from the default mode network of the brain, the fascination of the brain, that distinguishes ADHD.
So we're giving stimulant medications. Patients often ask, my child's hyperactive, why would I be giving them a stimulant if they're already hyperactive?
Well, consider this. Consider the brain's underactive and the child's hyperactivity.
The whole brain? The whole brain's underactive?
Just pretend like you're talking to the person on the street.
Okay.
And consider that the brain is underactive and that the hyperactivity is a way of stimulating the environment to bring the brain to homeostasis. That's a very simple explanation.
I would add to that more areas that are particularly underactive with ADHD tend to be in the frontal lobe. The frontal lobe is handling focus, concentration, attention, filtering out distractions, as is other areas of the brain. But when in speaking with patients, I think that's a helpful analogy, and you're trying to turn, with the medications, turn on the frontal lobe to do its job more efficiently and effectively.
Exactly. The prefrontal cortex is the seat of executive function.
Thank you. Yes, Dr.
If I could say a few words about it, the way I explain ADHD oftentimes to family members is I indicate to them that ADHD is a dysfunctional filtration system. So essentially, if you could think about a patient who has ADHD with having large porous holes in their filters, right? So somebody who does not have ADHD is able to cut out extraneous noise. A car drives by, they're able to focus on the matter at hand. They're able to listen in the classroom or read their book. Somebody else is tapping a pencil. A child with ADHD has porous filters, so they hear that tapping repeatedly occurring. The medications that we give undoubtedly influencing the prefrontal and frontal cortex of the brain, but also some of the data that we know already indicates that there's influence in two systems primarily, the dopamine and noradrenergic system of the brain.
So pulling together all the information we've been talking about, new patient in your office diagnosed with ADHD, we're thinking about best approach. Therapy should include medication management, behavioral treatment, connecting with the patient, educating the patient. When we think about medications, we're thinking about stimulant medications, first line, and we're thinking about where in the brain those stimulant medications are having their impact, which tends to be in the attentional networks, in part the frontal lobes. The decisions we are making for our patients, there's a science behind them. This is not just trial and error with medications.